Hello.
Good evening, everyone. Welcome to another session of Masterclass, where we bring across unique cases and their presentation from students across the India. So today we are pleased to have a case presentation by two of our students, Dr. Shiva and Dr. Arya, who are critical care residents from the Department of Critical Care at Yashoda Hospitals. And to moderate this, we have Dr. Mohan Maharaj sir, who is a seasoned and well experienced teacher, joining us from Vizag. Welcome, sir. And we also have Dr. Venkatraman sir, who is a faculty well known across India, and two seasoned examiners, ready to start the session. Over to you, Dr. Shiva and Dr. Arya.
I think Dr. Sunil Pandya sir also will be joining soon.
Yes, sir.
Okay, right.
Sir, did you call him, Ravi?
Yeah, good evening, sir.
Hi, good evening.
Yeah, please go ahead.
Dr. Kola. Happy to see you.
Thank you, sir.
Yeah, start, Dr. Shiva.
Sir, it is showing the. Is it showing the presentation, sir?
Share the screen.
You have to share the screen.
Yeah. Yes, perfect. Please.
Good evening. Good evening, sir and teachers. I am Dr. Arya.
Good evening, sir. I'm Dr. Shiva.
We will be presenting, sir. Actually, it is not showing properly.
Next slide. I think it's showing.
Sir, I cannot see, sir. But
you verified that.
Sir, actually, I cannot see the presentation here. We cannot see the presentation on our screen.
No, you open the PPT, no? Open the PPT. You open?
Yeah, it's open.
Maybe you need to reopen it again. Look into that. Anybody is there? IT guy?
Sir, is this working here?
Yes, perfect.
Okay. So, sir, good evening again. So, our case presentation is on a 32 years old, second gravida, post-elective, second gravida elective, post-LSCS mother who was brought to our ER in a hemodynamic unstable state with hypotension and tachycardia. And after examination, she was having continuous bleeding per vagina and from the abdominal suture site of LSCS. Elective LSCS was done at around 11 a.m. in the morning, and the patient presented to our ER on the same day at around 6 p.m. In outside hospital, the patient was diagnosed as atonic PPH. She received 4 unit of PRBC, 4 unit of RDP, and 4 unit of FFP as a treatment protocol. And before shifting here, she was given injection oxytocin and fundal massage.
Dr. Shiva, what is the shock index here?
Like on presentation, she was found to have a heart rate of 146, sir, and a BP of 80. Around it's 0.7, 0.8 to 0.9, sir.
Is it so?
What is shock index?
Heart rate by SBP, sir.
What was your heart rate?
So it is greater than 1, sir.
You said 146 by 80.
Yes, sir. It is greater than 1, sir.
So what is
Sir,
it?
so the patient is in shock stage, so indicating possibly hemorrhagic shock. Yes, sir.
Yeah, I can hear what Ram Kola is asking. Please answer.
Yes,
sir. Shock index is respiratory rate by heart rate by SBP, systolic blood pressure. In this case, it is 146 by 80 to 90. So the shock index is greater than 1, which is suggesting a patient is in shock stage.
What is normal?
Sir, 0.6 to 0.9, sir. 0.6 to 0.9, sir.
If it crosses 0.9, what happens?
Sir,
0.9 to 1, more than 1, what all does indicate?
Sir, that is impending shock stage, sir. Patient might deteriorate and go into the shock stage.
Okay. So is this a history? We are still in history, I believe.
So this is the first impression of the case, and now, sir, as patient, the shock index, as we discussed, sir, is greater than 1. The initial resuscitation in the ER was initiated. The obstetric team was promptly intimated. PPH code was activated, and blood bank was informed for massive transfusion protocol. The initial resuscitation was done according to ABCDE protocol. We assessed in the ER. They assessed airway. Patient was shifted here in our setup with NRBM mask at 15 liters per minute oxygen support. So we continued on that support till the ABG was available for further escalation, and immediately two large bore IV access in bilateral antecubital veins, 16 gauge gray cannulas were placed, and
Do you
patient was
have anything point of care, Shiva? Do you have anything point of care? TEG, TEG is there available with you?
Yes, sir. Available. Tech is available, sir.
Sir,
Okay,
TAG is
go ahead,
available, but we didn't use in this case.
In this case, we didn't use, sir.
Any reason? Just to know.
Sir,
Secunderabad has, right? So
sir,
point of
actually it
care
was
test is
not.
available, but not in the same unit, I believe.
Okay, okay, right. No, normally, Dr. Venkatraman Kola, I'm asking, these type of cases, tech is useful or not?
Yes.
Just to tell them, highlight.
Yes, absolutely.
Yeah,
So we
right.
come to that is important discussion, sir. Yes.
Yes.
Yeah, thank you. Thank you.
Sir, patient was positioned flat, and warmer was started to control the temperature of the patient, body temperature of the patient. Aggressive fluid resuscitation was immediately initiated with 0.9% normal saline. Approximately
What warmer has been used, Dr. Shiva?
Bear hugger warmer was used, sir, for this patient.
So, Bear-Harker warmer, is it sufficient, or do you have only anything like warm fluids have been given with the warmer?
Whatever the resuscitation fluids were used, they were like warm fluids was used, sir.
No, warm fluids means how did you warm it?
Sir, in a double circuit warmer to quickly warm the temperature, and also there is a inline warmer which was used in this case of in this patient.
Very nice, very nice.
Yes, sir.
Please go ahead.
So after initiation of fluid resuscitation, the injection tranexamic acid 1 gram, slow IV over 10 minutes were given, along with injection carboprost 250 microgram IM was stat given. In the meantime, ABG was drawn, and ABG was showing pH of 7.027, which was severe acidosis, and with bicarbonate showing 99.8, which is metabolic acidosis. PCO2 was 35.3, lactate showing 11.5, that is gross hyperlactatemia. Hemoglobin was 3.1, severe anemia was there, and potassium was strikingly 7.4. Chloride, possibly due to resuscitation, it was 111. Base deficit was 18.8 with anion gap 25.6. So our interpretation was severe high anion gap metabolic acidosis with concurrent respiratory acidosis and severe lactic acidosis. The patient was intubated in the view of dropping GCS, and as ABG showed, severe metabolic acidosis. And after that, blood product transfusion, that is massive transfusion protocol, as per the guideline, 4 unit of PRBC, 4 unit of RDP, 4 unit of FFP was given in 1:1:1 ratio. Along with, we started prophylactically 10 unit of cryoprecipitate because of uh, as we can say, these patients have low fibrinogen level. GRBS was normal, within normal limits. The after initiation of initial resuscitation, the quick evaluation in the year of the in year was done about the patient. General examination and systemic examination. Temperature was normal, maintaining 98.9 degree Fahrenheit, with GCS recently intubated and sedated and paralyzed. Pulse rate was 148 per minute. BP was hypotensive, 78 by 52 millimeter mercury on dual vasopressor support, that is noradrenaline, and at the rate of 10 ml per hour, and vasopressin at the 2.4 ml per hour. Respiratory rate was 36. Saturation was 94%. This was a correction which was done later. It was intubated patient. So it was on 0.6 FiO2. Patient was maintaining 92% SpO2 saturation. So pallor
So
was,
how much it becomes FiO2 at this point of time?
yes, sir.
You said FiO2.
Sir, FiO2 was initially, we started with 100% and we titrated down to 0.6, maintaining SpO2 of 94 to 95%. Sir.
What was INR here?
Sir, INR was,
Labs, they have not come to
sir,
lab.
labs are,
Okay, fine. Go ahead.
yes, yes.
It's okay. Go ahead with the ER presentation.
So, systemic examination, quick systemic examination, CNS. Sir, this total slide a bit corrected later. So, CNS is GCS was intubated, patient was tachycardic, S1, S2 was audible, no murmur was heard, tachypneic by in respiratory system, bilateral clear air entry was present. Parabdominal surgical wound with soaked dressing, diffuse tenderness and slightly distended. Renal system, patient is oliguric with very low urine output. And genitourinary system, patient has active pervaginal bleed. A quick focus revealed IVC was collapsed, bilateral dry lung with occasional basal B lines. Cardiac contractility was good, although it was a tachycardic window. E first was done to rule out if there is any collection in the dependent part or pouch of Douglas to uh, rule out uterine rupture condition of the uterine rupture. So after the initial stabilization and quick examination, the history was taken from the relatives about present and past pregnancy. Present pregnancy was uneventful. It was second gravida, term pregnancy, G2P2L2, booked case in outside hospital, 2 doses of tetanus toxoid taken. Pregnant in the pregnant period, antenatal checkup was thoroughly done, and there was no history of diabetes mellitus, hypertension, fever, coagulation disorder, asthma, or cardiological illness. Past pregnancy was 4 years back. It was delivered by LSCS at term, and no history of PPH in previous pregnancy. And after that, the normal blood samples were
Arya,
sent.
Dr. Arya, give a minute.
Yes.
Sir,
Yes.
do you want to ask any questions, Mohan sir? Before we go to the menu. Go back to the previous slides, Arya. Previous slide.
I think Dr. Kola, you whatever the questions coming on the message, you can check it.
Yeah. So, what is your diagnosis? See, you should have a chief complaints and then you should have a provisional diagnosis. You, at this point of time, should have a provisional diagnosis on board. Go back to the first slide. The previous slide.
Based on current history and the investigations so far, whatever has been done, we can we'll have a provisional diagnosis of postpartum hemorrhage or likely to be secondary to atonicity of uterus, and it might be likely due to DIC or hemolytic uremic syndrome or thrombocytopenic purpura.
What do you think is the reason here? You said DIC and multiple.
Our working diagnosis was postpartum hemorrhage due to atonic uterus. Patient is in shock, hemorrhagic shock, severe hemorrhagic shock with DIC, likely DIC. And
Fair enough. We are not going to differential. Fair enough. At this point of time, that is enough. So
Yes.
the question is, what is a PPH? How do you define PPH?
Sir, the PPH is in latest guideline. It is defined as more than 500 ml of blood loss
in
post
case of normal vaginal delivery, but in case of cesarean section, more than 1000 ml can be considered as postpartum hemorrhage. In the initial first 24 hours, it can be taken as primary postpartum hemorrhage, and from 24 hours to 6 to 12 weeks, it can be considered as a secondary postpartum hemorrhage. But it is not
a primary or a secondary?
It's a primary postpartum hemorrhage, sir. Immediately post cesarean section, patient was found to have a severe bleed.
You said it is a atonic PPH. What are the common reasons of PPH?
So
there are tone atonicity and written parts of placenta and thrombocytopenia, like coagulopathy disorders, and
sir, the 40 it is termed as that one is tone, second is tissue.
Trauma due to any genital tract, like vaginal tears, instrumental deliveries, episiotomy, like bleed from the episiotomy site can be there.
Which one is the most commonest among them?
Atony is the most common among all these.
Around 70% of PPH is from uterine atony.
So there were questions related. This patient initially, when the patient presented to you in a drowsy state, needing 15 liters of oxygen in NRBM, did we waited for an ABG to an indication for intubation? What would have been your indication to intubate in this case? And how do you intubate this case?
We have intubated with rapid sequence intubation using rocuronium, sir, and fentanyl induction. Patient GCS on arrival, GCS of the patient was low, but no, like she was able to maintain her airway. So
is this patient intubated by a critical care team, or is this patient been intubated by the emergency department?
ER, like in the emergency room, she was intubated.
So are you got the information? Assuming you both are there in the emergency first response team and received this patient, what would have been your approach? What would have been the indication to intubate this patient, and how would have been prepared for intubating? What are the concerns and challenges?
So as she was a pregnant female, her functional residual capacity will be low when compared to non-pregnant female. So we will be cautious, like regarding rapid desaturation.
Delivered, I believe. Patient,
Yes.
this patient was delivered post LSS.
Post that. And we also keep in mind about the airway edema. So difficult intubation in
Is this the physiological changes in pregnancy important with this history in this particular case? What is that which is threatening me?
in case of airway edema should be kept in mind.
Dr. Siva, listen to my question carefully. Is that the physiological changes in the pregnancy which is worrying me when I see this case and this ABG and this kind of presentation, or something else which will be causing problem to me?
Sir, apart from pregnancy related airway difficulties, as patient is presented with in shock, so sir, during induction or RSI, patient might go into severe hypotension and precipitate into cardiac arrest.
Okay. And anything else other than hypertension in this case?
So, so um, sir,
You
there is
had
chance
an
of
ABG.
yes, sir.
You have an AVG with you.
So there is a chance of injury that can.
You have a ABG with you. Listen to my case.
Yes, sir.
So what is that concerning in ABG to me?
Severe acidosis.
Sir, and potassium is
What kind of
potassium.
airways we call when such patients comes to us? What kind of threat of airways are these?
Physiologically difficult airways.
Very good. It's called a physiologically difficult airway. One is you are saying anatomically there can be a challenge with the edema and whatever changes happens during the pregnancy. But in this particular patient who is actually compensating with much of tachypnea, in spite of that, the CO2 remained to be 35 and you have a lactates of 11, pH is sitting at 7.
Yes.
The moment you take out that sympathetic drive, you will have a crash and you will have an impending cardiac arrest in them. So how do you actually prepare this case for intubation? That's the question. Can we actually add Dr. Padmaja madam also into board? The digital team is there. Yeah, Dr. Padmaja madam, go ahead. Davi, you can take care. So you tell Siva, so what is that precautions you will take during the intubation in this particular case? How will you prepare yourself?
Sir, as the patient has physiological as well as maybe anatomical difficult airway, once the patient comes in, we will initially start keep in mind our the peri-intubation cardiac arrest scenario, and we will start with high dose of as it was going on, we can increase the dose, and some fluid resuscitation was done to at least increase some BP, so that we can use at least fentanyl and
What are the steps you will do? You say you will have some volume replacement. You will give some blood products if available. You said rapid. You have a massive transfusion protocol. What is your massive transfusion protocol?
In massive transfusion protocol, we will be alerting the blood bank, and as we'll be issuing 4 units of packed cells, and along with 4 units RDP. And
What type of packed cells they issue? They cross match and issue, or they issue something else?
But in emergency situation, O negative packed cells are can
So
be issued in
if you
emergency.
have a massive transfusion protocol and you have these blood products available, those can be one way of resuscitating them. So optimizing the volume, keeping the drugs ready for resuscitation, and you should have the most senior person to take care of the airway. And what are the drugs to induce, and what are the drugs to give as a relaxant, and what is the rapid sequence intubation you will plan?
Sir, for intubation, we will use those drugs which are most cardiostable, not
Keto.
impending,
Name
more.
the drugs. Name the drugs. No theory.
Okay,
Instruct us.
sir, in this patient that was done with fentanyl, but etomidate can be used, and also ketamine will be a choice for.
Can you tell me any justification whether you will use ketamine or etomidate? Any recent evidences supporting them in this kind of unstable cases?
Any, sir, recent one study, sir, I don't remember the name, but a study was done with, there is, I guess, sir, no
What will be your choice?
no
Etomidate,
benefit between
etomidate,
ketamine.
ketamine, and fentanyl. What will be your choice and why?
Sir, can you repeat the question, sir?
What will be your choice of induction?
What will be the choice of among the fentanyl and ketamine and
Etomidate. You said the three names. Which will you
yeah,
choose?
the reasons?
Sir, sir, this patient was intubated with, sir, fentanyl. Sir, I would go for fentanyl only.
Dr.
And
Arya, Dr. Arya, you have not intubated, forget about it. But in exam, when we ask question, it is like you are there as the first responder. How will you intubate?
sir, fentanyl and rocuronium, sir.
You wanted to use any changes from Siva? Any other alternatives you want to use and why?
I will go with ketamine induction, sir, as patient is in a shock situation.
Okay, and what relaxants you want to use? You will not use any muscle relaxant to intubate?
The rocuronium, sir.
Why rocuronium?
Fast acting and
Did you get any information from your ER team during intubation? Any changes or any events happened?
No, sir.
no intubation was uneventful, sir.
Okay, Dr. Arya, you said 10 units of cryo in this case, and you said
Yes.
prophylactic. You used the word prophylactic. What does that mean?
Sir, without having a fibrinogen report, we initiated cryoprecipitate, 10 unit of cryoprecipitate.
Okay, why is that?
Sir, because in these patients in PPH, the first factor that falls is fibrinogen. So,
What will be your goal generally?
sir, more than 200.
In pregnant women, generally fibrinogen should be maintained at a higher level than the non-pregnant females, usually more than 300.
But what will be a cutoff? 200, 300. Both of you are varying your numbers.
Sir, I would
270 to about 200 to 300 should be maintained.
Why tranexamic acid?
Sir, tranexamic acid, as per women protocol and crash 2 protocol, it has shown to show some benefit in with patients having hemorrhagic shock.
When given within 3 hours of duration.
In women's study, it has been shown.
So how will you dose?
15 mg per kg should be given. 1 gram tranexamic acid is given in over 15 to 20 minutes. Less than 3 hours.
Okay.
Sir, any one repeat dose can be given if patient has bleeding after 30 minutes or even within 24 hours. If patient starts bleeding, then we can repeat one more dose of tranexamic acid.
What is the massive transfusion protocol? You said massive transfusion protocol activated. Why?
When the patient requires replacement of whole blood volume in 24 hours or 50% of the blood volume in 3 hours, or requiring of 4 unit transfusions in 1 hour, it can be considered as a massive transfusion protocol.
Okay.
No. Sir is asking, when do you initiate MTP, massive transfusion protocol? Is it right, Dr. Kola?
Yes, both are maybe interrelated, but sir, you can take some questions, sir. Padmaja madam is also there. Ma'am, you can actually switch on your camera and take some questions, ma'am. Padmaja madam, welcome. Can you switch on your mic and camera?
Kola, I'm traveling, so I may not be able to join for
You
very
can
long.
ask question. You can ask.
పర్లేదు మేడం పద్మజ మేడం మీరు ట్రావెలింగ్ అయినా క్వశ్చన్లు అడిగితే చాలు మేడం మాకు.
It's like take up.
Okay,
Okay,
okay.
go on.
Okay, next, why this 4-4-4? What is the reason?
Sir, actually 1:1:1 ratio was maintained, and as per proper study, it has shown some benefit over 1:1:2 protocol. But sir, in that study, it was given as one unit was one round was 6 unit of PRBC is to 6 unit is of RDP and 6 unit of FFP. In our hospital, we consider the blood bank has consider one round of transfusion is 4 units. Sir.
No, I'm asking what is 2:1:1 or what is 1:1:1? What is the 2?
Sir,
PRBC is the
2.
difference.
So what was the conclusion of the study? Was there any difference in mortality?
Sir, actually 24 hours and 30 days mortality benefit was not there. Those were equivocal, but in case of exsanguination, death by exsanguination in 24 hours, it was less in 1:1:1 protocols.
So in a resource limited settings, I can still
Sir,
probably use the other alternatives
Yes.
we were talking about. Okay, you go to the next slide. Go ahead.
So after initial resuscitation, the
What
routine
is that you are missing, both of you, in this case in ER? What examination and what is the expertise which should be there? Is it who are the first responder in this case? Emergency team, intensive care team, and somebody else?
Sir, obstetric team, emergency team, and
Was the
actually,
obstetrics team? I could not see any comments on obstetrics team in any.
sir, at the first line, we obstetric team was intimated. So
Where is the first line?
sir, initial resuscitation, just first line.
Okay, okay, go ahead. So what was their call?
Sir, and they opined
Go
for
to the
so
next.
they opined for atonic postpartum hemorrhage, and as per the protocol, that massive transfusion protocol, and was activated. So it was.
What was the obstetrics team's call? Next slide, next slide. Next slide. Next slide. At this point of time, what was the obstetrics team's call? What they wanted?
Sir, their call was to secure the source of bleeding, as there was continuously bleeding from parvaginal bleeding was there. So two options actually: surgical and non-surgical exploration, or non-surgical.
What other team member you would have been called or kept
Sir,
ready this time?
interventional radiology team was also included in the
Got the
management.
point now. Right.
Okay. Okay, go ahead and talk about the ER management. Sir,
What is
question.
the atonic uterus percentage in PPH?
Sir, around 70%.
Right.
Okay, go ahead with ER management.
Sir, in the year after the somewhat stabilization, blood samples were sent on complete blood count, RFT, LFT, PT, INR, APTT, fibrinogen, electrolytes, calcium, magnesium, blood group, and serology was done. Arterial line, after initial stabilization, arterial line and central venous catheter was secured. USG abdomen and pelvis was done as obstetric team has advised. So, these investigations came as hemoglobin 4.1, platelet 60,000, PCV was 13.1%.
Don't read the abnormal values. You can read and highlight the problems.
Hemoglobin, hemoglobin was 4.1, which indicates severe anemia. Platelets of 60,000, suggesting thrombocytopenia, and PT of 49.3 seconds, which is more than 2.5 times the normal value. and APTT being that INR being 4.09, which insinuates a coagulopathy state. Fibrinogen being 99, which is much less, and creat being 1.3.
What is your take on this labs?
Fibrinogen being 99, in case of pregnant female, it is considered as much lower value. So our resuscitation with 10 units cryo.
What is your take? Means why I'm asking, after this information, what will be your diagnosis based on this investigation?
Sir, patient is in hemorrhagic shock with multi-organ dysfunctions, and patient has coagulopathy, AKI, and also ischemic hepatitis, as bilirubin, SGOT, SGPTs were high, and patient has hyperkalemia.
So,
With raised.
So patient, and also as per coagulopathy, that is patient might be in DIC.
labs in this is not fitting into this patient's parameter.
Yes, sir.
Which laboratory parameter in this is not fitting into this patient parameter? You said DIC and all, but one of the labs are not fitting into this.
APTT, sir?
How come a APTT was absolutely normal with so much of blood loss, and you are saying the patient is bleeding everywhere? Was it a right report?
Initial report, sir, report was that, but we would have repeated the APTT.
Why hyperkalemia? What is your explanation for this?
Because of the multiple transfusions which were given in the outside hospital and here in our hospital, because of the
How many
multiple
total transfusions were given?
Multiple transfusions with the date of collection.
Sir, total PRBC was given outside 4, and in the ER around in the ER 4. So
And do they have any relation to the fresh collection, to the old collection? And Dr. Mohan sir is asking.
What I mean to ask is, like, for example, when you keep the blood bag in the blood bank, what are the changes happens in the blood bank in all the levels of lactate, citrus, and potassium and other things?
sir, in stored blood, there is increase of citrate levels and potassium levels.
Citrate
And-
levels increases?
Sir, there is citrate for anticoagulation. So when given in a large volume, there might be.
What happens in the blood bag? What are the things which increase?
Initially, hyperkalemia can be seen with the stored blood, but if the blood old collection,
Let me
Yes,
have a
sir,
very specific
that
question.
2-3 DPG can be.
How much of potassium rises with each unit of your transfusion? And how many times you see when you give a 4 units or 8 units, your potassium goes to 8? You must have been transfused many times, right?
Yes, sir.
So how many times you have seen you have given a little large volume in OT or in ICU and you land up in a potassium of 7.9 or 8?
not very frequently, sir.
Then the question is, how much potassium generally will rise if you have say 30 days old blood is there with you, each unit, and you have given 4 units also. What can be the reason, rational for this kind of hyperkalemia in this particular patient? Without transfusion also, this patient will have 7.9 pH or 7.9 potassium. Why?
Sir, hemolysis.
Why hemolysis? What was the pH of this patient?
Sir,
7.0.
So if such a severe acidosis, what will happen?
Potassium will come out of the cell, and
So this is a severe acidotic patient,
Severe acidotic,
7
uh-huh.
pH. It's not just transfusion. Transfusion do raises potassium in an old blood, but that number is not been always the same. What other electrolytes I wanted to see if you are been transfusing so many bloods? You are saying 8 units, 10 units, 20 units.
Calcium should be monitored.
So what generally happens to the calcium?
Hypocalcemia can be seen.
So what is the protocol? What is the protocol, Dr. Siva? What do you do when you see hypocalcemia or when you give a massive transfusion? What is your protocol and what should be done?
Calcium should be replaced by using calcium chloride or calcium gluconate.
Arya, any points from you? Do you use calcium as a standard supplements for all massive transfusions?
Sir, no, sir, this is it.
How do you do that? If at all I have to supplement, what is the indication to me to supplement? Is it a serum calcium level, ionized calcium level, total calcium level, or something else in the monitor?
Sir, ECG changes can prompt to replace potassium, sorry, calcium, sir.
What ECG changes you see in
So, hyperkinesia.
what is my immediate threat in this patient? One is bleeding, the other one is severe acidosis, the other one is hyperkalemia.
Yes, sir.
What is that you are doing in this case?
Sir, we counseled the patient, relatives, and opted for CRRT immediately. Start to initiate on CRRT, and before that,
How I will treat this hyperkalemia? My question is.
sir,
Will
first,
CRRT be an answer to me immediately?
sir, for hyperkalemia, hyperkalemic measures were taken. Calcium gluconate was given, and along with
10 units of
10
high
units
along with 25% dextrose and
nebulization.
nebulization with acetylene, and Lasix can also be used, but
In this case, Lasix, I'm not asking conventional hyperkalemia measure. I have a patient with 80 BP, severe acidotic, high lactatemia, 7 is the potassium, and the reason for that is something, we are not taken care of that.
Sir, also we can use bicarbonate for as pH is such low limits. So
Because
Bic-
how much time your CRRT or any dialysis machine take, this patient can go into a sine wave pattern and arrest in no time.
yes,
And you probably your your CO2 is 35. Can you go with your ABZ? So can you interpret this ABZ? I was not happy with that interpretation of ABZ. Go back to the
sir.
previous slide of ABZ.
Yes, sir. So this one is.
No, ABG slide. I'm not seeing an ABG slide. This one, right.
Sir, pH interpretation.
Severe high anion gap metabolic acidosis with
Concurrent respiratory acidosis.
why I have a respiratory acidosis?
Sir, actually, by compensation, it is much PCO2 should be much lower.
Why it is not there? What is happening? You taken this patient onto tube, you ventilating. Why your CO2 is still so high? It is relatively high.
Sir, it is before intubation.
After intubation, do we have a ABZ?
No,
I've
sir.
not seen anything.
No, sir.
Okay, can we go to next? So the CO2 generally should be well compensated to maintain the pH, at least at some point till your bicarbonate or CRRT takes place, because you are talking about saving this patient from cardiac arrest with that
Yes.
kind of things. Okay, go ahead for ER medicine. Mohan sir, any questions at this point?
No, the structured way of approaching ABG itself is important here, no?
Yes, sir. You want ABG flow, sir?
Yeah, no. The 7 steps how they are going, they can tell for the people who are basically to understand for in the IDCSM students.
Which is the steps of ABG?
First, ABG should be validated by calculating the H plus ions.
Okay, next, validated. Next.
Validated, and first most is to look for acidosis or alkalosis. pH less than 7.35 can be considered as acidosis, or more than 7.45 can be taken as alkalosis. Then it should be differentiated between respiratory or metabolic based on PCO2 levels. More than PCO2 of more than 45 can be considered as respiratory, and a bicarb of normal bicarb levels are 22 to 24, 22 to 26 with mean of 24. bicarbonate of less than 20 can be taken as metabolic acidosis. And the next step is to find out whether there is an acute or chronic.
So first, compensation is there or not proper compensation, or there is any additional metabolic or respiratory component. So the formulas are there, Winter's formula to
Okay, we'll go to the ER.
It's okay. It's okay. Little go faster because many people know, but we just want further. As Dr. Kola is asking about the diagnosis of through ABG, he was asking.
Sir, then anion gap and
Okay, next we'll go there. Next, okay.
so in the patient was shifted to ICU, and first thing was temperature monitoring with Beer-Hager warmer, the target of 98 Fahrenheit.
In ICU, there was no ABG. If the patient has 7 pH with potassium of 7 and patient was intubated, shifted up, there was no ABG done. Is that
Sir, one ABG was included.
any further ABGs or no ABG done?
Sir, ABG was done. One ABG is further investigation. The last column, last 2 rows, there are another ABG which was included.
Okay. So there was a ABG done.
Yes, sir.
Okay, go back to the previous slides. Okay.
Normally, whenever you do ABG, when you get an abnormal ABG, how frequently you are supposed to do for which cases?
With such high lactates, ABG should be monitored every 4 to 6 hourly.
4 to 6 hourly. What do you do? Suppose I have a ABG like this. How frequently you monitor the ABG?
Yeah.
Sir, we would do, sir, 6 hourly, sir. For
No. Please
ABG,
understand.
after this ABG, you will repeat a 6 hours ABG. Will the patient be alive for 6 hours?
Will you think that patient will be there?
sir,
If a
sir,
patient
Anyway, already
6.8
Soumya has answered within 1 hour.
6.8, 6.97 pH, if somebody came and you are resuscitating, when will you repeat a ABG?
sir, immediately within 1 hour of mechanical
Maybe
ventilation.
half an hour also because you won't get that
It
much
is
time.
after your resuscitation, you wanted to see.
Yes, sir.
It should be after the resuscitation, you wanted to see the pH to be better, the bicarb to be better, the overall the
Yes, sir.
patient clinical situation is how you have to know. How can you wait for 6 hours? These patients, most of the times, this patient is lucky that this is a PPH case and a hypovolemic hemorrhagic shock. In a septic patient with a pH of 7 with a lactates of 11 will not survive more than an hour if you don't resuscitate them aggressively. Okay, go ahead with the ICU management. So what is the goal if you are talking about those lactates and hour or within hour? Why that has all been there?
Sir,
Make sure the perfusion
correct.
was adequately managed.
Okay.
And metabolic corrections are
Okay, metabolic
patient is-
corrections. Any other clearances?
Any other, sir?
Any other clearance which will be an indicator of
So lactate clearance will be
lactate clearance. So there will be controversies when you talk about lactate clearance or lactate trend, whether that
Yes.
is really a reflection of the outcome or not. But that is a different. But any patients with such a bad ABZ after resuscitation or after correction, you will be doing one more ABG to see, because that is the point of quick test which will give you back the reflection. Okay, go back to your ICU management. Mohan sir, you take over, sir. Next, again, start the second slide, Arya.
In the ICU, patient's temperature was continuously monitored by using oropharyngeal temperature probe and covered with Beer-Hager warmer by targeting the temperature of 98 Fahrenheit. And she was on lung protective ventilation strategy, and she was on dual vasopressor support with noradrenaline and vasopressin. After multidisciplinary discussion and along with family, CRRT was advised for the patient in view of severe shock along with the hemodynamic.
Can you tell me on what conditions you do CRT? Already some questions have been discussed in this. Because of the hypertension, because of this one, you're going for CRT, right?
Severe in case of hypertension with dual vasopressor support.
Is
it
severe
is
acidosis better corrected with the CRT or better corrected with the normal sled?
CRRT.
With CRRT better corrected.
Are you sure? Because the flow pattern, flow speed, and those things are different with the CRT and the normal side. This one, no?
Sir, actually, it is a slow exchange, but sir, metabolic components can be manipulated according to the changes.
What flow setting and what speed, what ml you are going to use it?
CV.
In CRRT, usually low flows are used like 100 to 150 ml per minute, and in case of SLED, 200 ml per minute of flow is maintained rather than compared to normal hemodialysis.
The CVV HDF mode for CRRT was done. Sir.
Okay.
Fourthly, blood gas was monitored along with hemoglobin, platelets, and PT with INR. The continuation of massive transfusion protocol was maintained in view of ongoing blood loss and anemia. We have transfused 4 units PRBC and along with 4 units of FFP and 4 units of RTP, along with 10 units of cryoprecipitate was transfused in view of low fibrinogen. It was supplemented with calcium chloride of 1 gram slow IV infusion over 10 minutes, along with oxytocin IV infusion was maintained in suspicion of uterine atony. Carboprost of 250 micrograms IM, one more dose was repeated. Patient was initiated on broad spectrum antibiotics, and a quick focus was done to check the volume status of the patient in view of massive transfusion. We just monitored the volume overload state of the patient to check, and in view of ongoing hemodynamic instability, and we are able to achieve hemoglobin levels and fibrinogen levels, but the hemodynamics continues.
No, I didn't get the sentence. In view of hemodynamic stability, we achieved means what?
No. In case
This
were able, after initial resuscitation, we were able to maintain hemoglobin levels to a mean range of around 6.
When you transfuse this one, you're done hemoglobin where in arterial or venous blood?
sir, venous blood.
Venous blood. So you are only giving massive protocols, and how do you say that this venous blood of hemoglobin is same as what you are transfusing? How do you believe that this one is better? Number one. Number two, how long it takes to correct the hemoglobin to believe it? And you are doing in the lab hemoglobin, or you are checking in the arterial hemoglobin? What you are going to see? Or you are going to look into the PCV, or you are going to look at only the HB? You believe that?
Sir, with PCV and hemoglobin level in sir quick availability was with
Your attention,
ABG.
please. Med call
Was
9th floor, NS3, room number 975.
so ABG was available on bedside.
Med
So
call 9th floor, NS3, room number.
So you can mute for a minute when that mic is coming. Now, when the mic is stopped, you can talk. Is people are available for med call, I believe. I think, is it okay? Can you speak? We are not able to hear Shiva.
Please unmute yourself, Shiva.
I think Dr. Ravi, you can also join because Kola is not there. Please join, Ravi.
Yes, sir. Arya, please unmute. Yeah.
So, sir, actually, for hourly or 2-3 hourly monitoring, we used ABG hemoglobin. But, sir, also we sent for 6 hourly hemoglobin, 4 to 6 hourly hemoglobin in the lab. And, sir, with that, we guided our transfusion.
What are your targets?
Usually in blood transfusions, if you give 500 mils of blood or PRBC, and what is the chance of how much hemoglobin normally usually can rise?
1 unit PRBC can give a rise of 1 gram per deciliter.
On an average,
Normally, when do you supposed to check in the normal patients? In massive protocol in the shock, anyway, you need to check again. But usually in the routine cases, how frequently you check? Once in?
sir, in ICUs we check if there is no bleeding tendencies, we go for daily once. Sir, daily
You
once,
only when you transfusion, right? Not without transfusion, daily once.
not without transfusion or bleeding tendencies.
No. What are
Sure.
your targets of
It's-
resistance?
Yes, sir.
What are
Ravi,
your
what you can please
targets of
confirm.
resistance?
Sir, couldn't hear you, sir.
What are your targets of resuscitation?
Sir, in this case, in this patient, our target of resuscitation was achieving a hemoglobin level over transfusion trigger, or at least transfusion trigger, or in by PT and APTT more than to reduce by
HB of
1.
7 gram per
1.5.
deciliter, PT of more than 1.5, normalizing to more than 1.5 times the normal.
And sir, with platelets 50 to 75,000 at least, sir.
Any other parameters which you want to target?
Sir, INR less than
Fibrinogen to be more than above 150, sir.
150. What is normal value of fibrinogen in pregnant patients?
In pregnant patient, it is usually 400 to 600.
So at least you'll be targeting half of that. That should be around somewhere around
200, sir.
200. Okay. So any other targets?
Sir, INR should be less than 1.1.
Any other?
No, sorry, what is the 200 target? I missed the voice.
Sir, fibrinogen, sir.
Okay, right.
Any other
Anything
target?
urine output discussed, Ravi?
Sir, sorry, sir.
Urine output.
Anything urine output discussed?
Sir,
No, sir, not yet.
What are the
Great.
targets? What are the targets when you resuscitate these patients? 1, 2, 3, 4, 5.
Yeah, repeat all the things, whatever you said now.
Hemoglobin of more than 7 gram per deciliter with and a PT of more than 1.5 times the normal value, and platelet count of more than 50,000 to 75,000 with INR of less than 1.5 with fibrinogen of around 200 and maintaining a urine output of around 0.5 ml per kg per hour at least.
See, you told us the lab parameters. What is that the first goal for you? What is the vitals which will monitor? And what will be a goal?
Sir, blood pressure with urine output and
The blood
tachycardia should.
pressure. What will be the blood goal of you?
Sir, for
Increase in systolic blood pressure by 30 rule of 30 can be considered, sir. SBP of increase in SBP of more than 30 mmHg with a decrease in heart rate of 30 beats per minute.
What is your goal? What is your quick goal? Will you keep on doing this mathematics there? What is your goal? What is your simple goal? Why are you complicating? What is the blood pressure you will maintain?
the blood
A
pressure.
map of more than 65.
Yes, simple answer is map of more than 65. By how? You will probably use blood products if available, volume if blood products are not immediately available, use vasopressors in the immediate scenario if it is not there, and then you resuscitate and get those goals. And urine output, as sir was particularly mentioning, 0.5 ml per kilogram hourly. What is that implication of urine output?
Adequate renal perfusion.
Is it renal perfusion? Arya, what is the importance of monitoring urine output?
Sir, sir, perfusion, tissue perfusion, it is an indirect
The
marker
site
of.
of perfusion, marker of perfusion. It's not just about kidney. It's not just about only kidney. It is about the marker of what are the other markers of perfusion?
Lactates.
And the other? What are
CRT.
clinical markers?
CRT.
What is CRT?
Sir, capillary
Capillary refill time less than 3 seconds to be maintained.
So what is the comparison between CRT and lactates?
Sir,
Which one is better? Which one we are using?
CRT is better in terms of recent outcomes in
Recent
studies.
both should be monitored.
What is the
not
recent outcome trial which is talking about CRT?
Sepsis 2026 guidelines.
Not
Sir,
sepsis.
forgot the name, sir. Sir,
Andromeda trials, but Andromeda trials, both Andromeda 1 and 2 shock
1 and 2.
was done on what patients? Are they hypovolemic hemorrhagic shock patients?
Sir, not only hemorrhagic shock, but in general patients, sir. Septic shock patients.
So what will be your challenge in this kind of situations with hemorrhagic shock in Indian scenario?
Sir, in Indian scenario, women or in general population has low blood volume with anemia, so
Will be the
patient
major
also sir,
limitation
for
in Indian scenario.
CRT for CRT, it is a complexion which might get into the measuring of
The melanins and the technique, the objective variability, the subjective variability between individuals, the melanin and the colors, all that can be limiting factors here.
yes, sir.
What are the three clinical signs of perfusion or markers of perfusion? You said urine output, CRT, and the other one?
The neurological.
Lactates.
Neurological
That's
windows.
not clinical. Dr. Siva, listen the questions carefully. Okay. What are the other markers of perfusion other than lactates in lab?
So neurological window.
Clinical, you said neurological, the capillary refill time, urine output.
Urine output.
Lab, we said lactates and anything else which has been used in other, if not
PCV can be used.
PCV, how?
For volume resuscitation, it can be a guide for.
I'm asking what are the markers of perfusion, lab markers of perfusion, which were used in septic patients and others. Mixed venous oxygen saturations were been considered earlier. Okay. Okay. Go ahead.
After the initial resuscitation with blood transfusions and renal replacement therapy, patient was maintaining it vitals of tachycardic of 122 beats per minute with a blood pressures of 86 by 52 of mercury, at saturations of 93% on with a FiO2 of 0.6. She was found to have persistent bleeding and soakage of multiple gauze pads, confirmed ongoing PV bleed. Uh, uh, the patient being in hemodynamically critical condition and continuous bleeding per vaginum and the surgical site. A multidisciplinary team meeting was decision was taken to go for non-surgical modalities like selective arterial embolization by involving the intervention radiology team.
Before
And
going there, what are the other medical options which are available for you?
Sir, in this patient, the coagulation factors will be deranged. So, in that case, we can try with Novo 7 factor, recombinant factor 7
No,
to
no.
cease
Medical
bleeding.
options to control the bleeding, not
Yes,
to treat the bleeding. See, control the bleeding. You have used some drugs, right?
yes, sir.
What are the drugs which you have used?
Tranexamic acid was used.
Okay.
Sir, for this patient, gynecological point of view, sir, with
What dose of tranexamic acid used and why you can use, and what is the benefit? And what is the mechanism of action of tranexamic acid?
15 mg per kg dosage of tranexamic acid, 15 mg per kg. Mechanism of action is it is an antifibrinolytic action which inhibits the plasminogen activity and which inhibits the breakdown of fibrin clots.
What is the major complication of tranexamic acid?
Sir, with tranexamic acid, we have to go slow injection. Other than that, if fast bolus was given, hypotension can happen, sir.
What is the complication? Complication is coronary spasm.
Oh.
It can cause coronary spasm.
Yes.
So, in other words, any other drugs which are available for medical management other than drugs which are used to control the bleeding, blood products, drugs.
Blood products.
Other than
Thrombin concentrate complex can be given. 3-factor, 4-factor, and also, sir, fibrinogen concentration can be used.
Okay. So, in which patients you want to use PCC or fibrinogen concentrate?
Prothrombin PCC can be used in cases where we need a low volumes, where we
Okay.
cannot use higher volumes.
Yes. So, when you're needing large volumes of blood for controlling or correcting the coagulation abnormalities, probably you will resort to using PCC if there is need for large volumes, because there will be most of the time shortage. Second would be to avoid volume overload. Third would be to avoid
Sir, if there is any bleeding complication.
reactions, because you're using Okay. Now, I was asking any other drugs to control the bleeding from the obstetric point of view. Any other drug which you have missed here?
Oxytocin, carboprost, carbitocin, methergin.
And
So
methergin, oxytocin. Yes, sir.
Was methergin given?
No, sir. In case of methergin can be is contraindicated in case of hypertension.
But
Was
sir, we didn't use in this patient. Carboprost was used.
Carboprost and oxytocin was used in this case.
Okay. Okay. Yeah, please continue.
A total transfusions of so far 12 units of PRBC was given, and along with 12 units of FP, 12 units of RDP was transfused, along with 20 units of cryoprecipitate was transfused so far. On Further evaluation, hemoglobin, there is an increase in hemoglobin of 4.1 to 6.2, and platelets were increased to 86,000, with a decrease in PT of 33.6 seconds, and INR was corrected to 2.8, and fibrinogen was increased to 219 mg per deciliter, and a little improvement was seen in creatinine levels of 1.17, and transaminitis was also reduced with repeated ABG suggestive of normal acid-base balance was achieved with lactates of mildly elevated lactates of 4.8.
This was after.
Uh,
So this values were after 4 units of PRVC, FFP, and RDP, and 10 units of cryoprecipitate. So, sir, we went in the early day 2. We opted for definitive management, and patient was shifted to cath lab as soon as possible with right femoral artery approach under fluoroscopy. Dye spillage was detected in the left uterine artery. Left uterine artery was selectively embolized. Sheath was in place, and appropriate dressing was applied. Bleeding gradually ceased. So, sir, this was the spillage, and this was after embolization, sir.
Any other complications of the embolizations you can see?
Sir, complications, sir. Sir, as sheath is placed, sheath hematomas, sheath entry point, bleeding, oozing of blood, and this can happen. And sorry, yes. And also, sir, dye is used for that. Allergic reaction can also happen with AKI can precipitate if dye
Who are on
related.
the standby at the time required?
Yes, sir.
Any standby people, surgeon?
Sir, any standby surgeon, the ultimately, if it had failed, we we discussed about the hysterectomy for ultimate goal of management, sir. But this embolization stopped the bleeding, so hysterectomy was not done, sir.
Yeah. If it is in the previous hospital, the age and all, what is the primary? She's second. I mean, how many children she has?
Sir, this is the second pregnancy with
Second
the
child.
live.
They were planning in the previous hospital if they would have gone for, they don't have embolization, if they gone for hysterectomy,
Yes,
what could have been the issue?
sir.
Family was not complete.
Sir, we should talk with the relatives, and specifically the mother if she is in condition to speak, and also her husband regarding the family planning, and we should take them into confidence before going into hysterectomy.
But Dr. Arya,
Yes, sir.
looking into
What is the advantage of keeping the uterus and the ovary rather than hysterectomy? Please go ahead, Kola.
Yeah, good question. Is this the only family planning or something else also has a role from your genital systems, including your uterus and ovaries?
Uterogenital.
Yeah. The question is this the only for family planning or there is any other uses of your uterus and ovaries?
The changes between the uterine embolization and the hysterectomy.
Sir, if there is continuous bleeding even after embolization, then we would
You'll go for it, but what will be the implication of doing a maybe a total hysterectomy with oophorectomy and all that, what will be the other implications in such a young female?
The hormonal changes.
So those all can be also equally challenging. My question is, see, assuming the same patient needs a hysterectomy surgically because of the different problems in spite of the embolization, will your family planning and child or children's completion will be our priority? Or suppose this same patient would lost that baby also, the dead fetus, and this is the first time. What will be the ethical issues and how will you approach in these situations? Assuming the baby is, we lost the baby during the process, and this is the first pregnancy, but the mother is bleeding. You have attempted embolization, you are not able to succeed. What will you do? Will you go ahead and do a hysterectomy, or you will just wait for a family to complete?
Our primary goal is to
Save the mother.
Save the mother, sir. We'll
So
go
if
ahead
there is
with
an indication to save the mother, the second life, fetal life, family planning, completion, all will come secondary.
Yes, sir.
But if there is a scope and chance, as Sir said, you have a scope of doing alternatively, like embolization or something where you can actually you save your uterus or organ, then you probably can do it. Otherwise, if that is the
Yes, sir.
requirement, you will do. But I have a different question to both of you. One is family and life and saving. In this situation, if I have two options, one side my obstetrician says I need to go and do different procedures. What are the different procedures I can attempt during this PPH, atonic PPH?
uterine massage, bimanual compression.
Sir, starting from the OT table, we can do start uterine massage as in the third stage of labor. It is indicated in AMTSL, active management of third stage of labor. Then bimanual compression uterine massage can be given, and surgical sutures can be applied, and
What is the sutures called?
balloon tamponade effect can be
Uterotonics can be used.
This is
Peeling sutures in the intraoperative period.
Then
Arterial ligation,
which arterial ligation?
internal iliac artery.
uterine internal iliac.
Uterine, and followed by, if further required, internal iliac artery.
Yes.
Then if that is not working,
Compression of the aorta.
how do you do a compression of the aorta?
For a temporary purpose, compression of aorta can be done, but there should be a definitive management to reduce the bleeding. So, internal aorta.
Okay, coming to this open surgeries like internal artery ligation or uterine artery ligation and hysterectomy versus this, what will be my challenges when my surgeon is ready and I don't have a interventional radiology guy? I have to go in these situation as the patient initially presented. What will be my problems?
Sir, firstly, with anesthetic complications, as patient is hypotensive and in shock, so anesthetic drugs should be given carefully, uh, should be chosen carefully, and also, sir, in as patient has a deranged coagulation profile, there might be a chance of additional bleeding in case of open surgeries.
If it is a DIC and bleeding, if you open the abdomen or if you go to your pelvis and handle these vessels, you will always also have a risk of this diffuse ooze which is coming. And we now this point of time you are sure there is a particular bleeder, but you are initially said it is an atonic PPH and there is a diffuse ooze, and you are also bleeding from your all the raw areas which you handled. Then you can be a vicious cycle of continuously oozing from these raw areas, which if you go and open and handle this. So there will be like a complete cycle where the surgical team and obstetrician wants the coagulopathy to get better. The bleeding will tend to actually keep on worsening. You give transfusions, that leads to further bleeding because of your improving pressures and all. What
Yes,
will
sir.
be the complication of this situation? If you suppose you used so many blood products and you are into now there is an embolization and ligation, assuming this patient started dropping his saturation, what must have been happened?
Transfusion associated complications like trally or tracho can be suspected in when the patient is having hypoxia, desaturation.
What is TACO? What is TRALI?
Trally, transfusion related acute lung injury, which definite the acute lung injury, where there is definitive mechanism was not known. Uh, Transfusion associated circulatory overload, in which there is
Cardiogenic pulmonary edema.
edema.
So which is common here when you have a massive transfusion?
Trally.
Which is common, TACO or TRALI?
Sir,
Oh,
TACO, sir, if fluid overload is there in TACO.
What is the condition which you are treating? You're saying hemorrhagic hypovolemic shock.
Yes,
So how TACO will be there? You will load them with that. It's not that it's not possible. The most common complication which land is TRALI. Just because a
sir,
question is asked twice, that doesn't mean your answer should change.
no, sir, for this patient,
Okay, what is the other organs which can get affected? Suppose my patient's urine output didn't improve.
sir, there will be venous if there is overload, then there will be venous congestions.
Will there be overload in this case? What is the cause when my patient's urine output doesn't improve?
The
If
patient
my patient,
can
this
have
many
AKI.
patients, AKI slowly
AKI.
worsens and the urine output go down. What is the
Yes.
common reason?
hypertension related
Go ahead.
renal,
Hmm.
hypertension related renal injury like
Okay, hypotension, hypoperfusion,
pre-renal
renal
AKI.
or hypoperfusion induced acute kidney injury, which may be established, it may take a longer time. You need to
Yes.
maintain that. What can be the other differentials in those situations for AKI?
Acute tubular necrosis can be seen in case of massive transfusion and hemolysis.
What are the other things? Suppose I have an acute kidney injury, anuria in these situations, kidney is not opening up. In a pregnant lady, postpartum AKI, what are the other differentials?
The other differentials, patient,
Not in this case. I'm asking what will be the differentials?
sir, patient might have HELP syndrome, which can
We'll
cause
ask for
AKI.
a previous history of preeclampsia, HELP syndrome and all one. Okay, anything else? In HELP, we see AKI.
Sir, not routinely, but can be seen.
HELP syndrome, what is the full form of HELP?
Hemolysis, elevated liver enzymes, and low platelet.
There is kidney injury there. So it can be a part of
Hypertensive, sir, hypertensive kidney injury can happen.
yes, it can be a part of preeclampsia. Okay, agreed. Anything else? What are the other differentials in pregnancy with acute kidney injury?
Sir, TTP HUS can happen.
TTP or HUS?
Sir, HUS.
HUS. So pregnancy associated HUS can be one of the other differentials. How do you know that all? Whether it is related to hypoperfusion or related to HUS or related to health?
Sir, HUS, for that, HUS patients can show cystocytes, elevated LDH.
HUS patients can
Go ahead.
Sir, can have cystocytes in peripheral blood smears with low platelet and anemia would be present, along with LDH would be present with severe AKI, elevated urea creatinine levels. And for TTP patients, we can differ. This might be same with TTP patients with along with the differentiating factor might be order of
Okay, hepatopathy. In this case, if my liver enzymes keep worsening, what are my differentials? You said my liver enzymes improved. If my liver enzymes keep worsening,
the one would have been HELP again, and AFLP, acute fatty liver of pregnancy, can be suspected.
what will be the first problem if I think the first diagnosis if there is a worsening liver enzymes in this situation? You said 4,000, it would have been gone to 8,000. What would have been the first diagnosis? What was your
Ischemic,
diagnosis when
ischemic hepatitis,
the first
hepatopathy.
diagnosis will be ischemic hepatitis? And generally, ischemic hepatitis, once your blood pressure improves, your perfusion improves over a couple of days' time, it should improve. If it is not improving, that is a point of no return or a bad damage, or the other differentials, which as you are saying, AFLP1, and any other differentials,
Sir, and normal hepatitis,
other non-pregnancy related liver injuries
pregnancy
can be.
related.
Okay, what are the markers of liver injury and recovery?
So it is diagnosed by a Swansea criteria with.
Now, what are the markers you use here to see that my liver is recovering? For example, you said AF.
Oh, sorry, sir. Sir, SGPT, SGO transaminitis is coming down, and with improving coagulopathy, hypoalbuminemia. Sir.
See albumin levels to see why patient is improving or not in acute liver failure.
Sir,
What
no,
are the
sir.
markers? One is you said coagulopathy. I see platelets. What is that I see in coagulopathy? Why such a vague answer? What is that particular test which we see as a marker of liver recovery?
What do you believe in single most?
What is that coagulation test which you do to see the liver function test? What coagulation test you see?
INR.
INR. It's not just coagulation, it's INR. And anything else?
Sir, APTT also, PTINR, APTT.
Among them, which will you choose? INR or APTT?
INR, sir.
Why not APTT? You dragged your own question. Yes, in acute liver failure, you may have both the arrangements, but why we take PT as a marker, not APTT? We'll go into those basic questions of how we monitor PT, what is intrinsic pathway, what is extrinsic pathway, which are the factors which actually been synthesized by liver, at what is the time.
What enzymes, which factors is important in intrinsic and extrinsic also?
So what is the typical characteristic of AFLP? Will it worsen after delivery or it should improve after delivery?
Sir,
improve after delivery.
Sir, it may improve, it might not improve after delivery. Sir, for these patients, actually, liver transplantation should be considered as a
No,
definitive.
answer the question what sir is asking. Liver transfer that can be not later answered.
My question is, if I have a patient with AFLP in pregnancy, I delivered, what should be the general or the course of illness? It should improve or it should worsen, or it may worsen is a different. What ideally should happen? What is the course?
Sir, it improves, sir.
So these are all pregnancy associated complications, which generally termination of pregnancy is the treatment of choice. Post that, most of the patients should improve. Yes, as you said, there may be a small fraction which may actually drag and complicate further. But that is the treatment of choice. If you have delivered the baby, ideally the patient's AFLP, preeclampsia, HELP syndromes, all this ideally should improve. If they are not improving, always think about an alternative possibility or a cause in them. Okay. Next slide is the last slide or
First thing is termination.
It is just the recovery part. Fresh bleeding was stopped. Drain output is minimal. Hemoglobin, platelet levels, and INR were holding on. No further deterioration. With adequate transfusion and volume replenishment, hemodynamic parameters were stabilized. CRRT was stopped. SLADE was done for oliguric AKI and de-resuscitation. Urine output was gradually improving. Metabolic acidosis were corrected. Sensorium improved to GCS at E3 VT M6. Spontaneous breathing trial was given on day 3, and it was extubated. POCUS was acceptable with 1.5 IVC, 1.5 centimeter with more than 50% variability. Dry lungs with mild basal V lines. Sips of water after extubation was allowed and followed by soft diet. So out of bed mobilization was done on day 4, and patient was stepped down on day 4.
okay?
So this is the diagnosis. Atonic postpartum hemorrhage progressed into hemorrhagic shock and DIC, managed with massive transfusion, CRRT, and left uterine artery embolization.
Okay. What are the other medical therapies available for this kind of massive blood loss or a massive PPH?
Sir, that recombinant factor 7, Novo 7 can be
Any
used for.
evidences in support or against?
Sir, in obstetric guidelines, they don't suggest for as a treatment of choice, but it can be given as an adjunct treatment.
As a rescue therapy, but what is
Yes.
the limitation for it?
Sir, thrombotic complications can be precipitated.
And what is the most common limitation for you to give? You're giving tranexamic acid left and right, but why can't you give this? What is the problem? Tranexamic acid also can have a thrombotic complication. What is the other common problem?
Reaction,
The
transfusion.
reactions.
What is the
I don't
cost of your?
cost is high, very high, sir. Yes.
What is the cost of dose?
Sir, cost of this
Factor.
Dose. What is the dose and cost of single dose? If you know the limitation. It is not just the complication or thrombotic complication alone.
no, sir.
What happened to the renal recovery of this patient?
Sir, with CRRT followed by SLAD, patient gradually and also volume replenishment, urine slowly opened up, started pouring, and at after recovery, at the recovery phase, it was coming with 25 to 30 ml per hour as an average. And it was a prerenal AKI, so creatinine levels has gone down.
Anyone have any questions related to the PPH cases? So, Mohan sir, any final questions?
No, Dr. Padmaja, Durga Padmaja madam has put 2 questions in that. They can type the answers in that.
Yeah, sir. Go ahead, sir. ఎక్కడ ఉన్నాయి అంటే చార్ట్ లో ఉన్నాయి సార్. I think those 2 we discussed, sir. Metabolic acidosis, hypotension. What are the target ventilation?
Yeah, already discussed.
Okay. Any questions from you, Ravi, or any points to add?
That's it, sir. I think they have discussed about factor 7. At what point of time you want to consider giving factor 7, and is it indicated?
Again, actually, indication is against using factor 7A. But if we cannot able to control the persistent bleeding, can be used. Factor 7A can be used.
And what are the criteria which should be met before considering giving factor 7? Or you just want to
And
give
after
factor
medical management, oxytocin and tranexamic acid before embolization, at that point of time, we can give
dose?
sir.
Okay. So, that's not an absolute indication. That's an off-label indication to use factor 7 here. One. Second would be you need to correct your, all the parameters, whatever your targets which you told should be achieved before considering even to use factor 7. So it will not come early. Obviously, there is a debate whether we should use it early or late. Okay. But at this point of time, you will consider it when all the criteria are met.
So in an exam point of view, when a PPH case comes to you,
Yes.
for all of you, those who are appearing for both the DM, DRNB and IDCCM, the examiners will expect you to handle the non-obstetric part of it. So more questions will be non-obstetric part of it. For example, resuscitation, acute care, stabilizing hemodynamics, stabilizing metabolic parameters, stabilizing coagulation parameters, talking about indexes, talking about perfusion, maintaining organs. These will be your basics. Okay, even sometimes these questions related to the interventional radiology and all will be add on. What are the procedures you can do? But the more focus will be restoring the physiology back. How are you actually able to handle? What is a massive transfusion protocol? What are the DIC related complications? What is the transfusion related complications? What are the target organs which gets involved? How are you going to manage? This is the flow which will be dealt here. Both Siva and Arya, I think both of you have attempted well, and the coordination was missing. Both of you are answering different things and different times. But anyway, it's always a learning experience. Over to you. And thank you, Mohan sir. I think you have been
Thank you, Shivan. Thank you, Arya, for your
Thank-
good. As I said, not only attempt, I think you have done average well.
I think,
Thank you, Dr. Kola, for accepting and making me part of this.
Thank you, sir. It's
Thank you,
always
sir, for being there. And I think the session went for close to 1 hour 40 minutes, which is quite an exhaustive session with a lot of discussion happening. Thank you, sir. Thank you for joining.
Thank you. Thank you all the participants for joining. We conclude the session. Thank you.
Thank you, sir.
Thank you,
Thank
sir.
you, sir.